My name is David Weil. I'm a transplant doctor, and I wrote a book called Exhale, Hope, Healing, and a Life in Transplant. It's a behind-the-scenes look of the emotional ups and downs of a transplant program, both from a patient's perspective and from a physician's. Early on in my career, my father developed liver disease that required a transplant. So after being the doctor, I was now being the family member. Having to see it from that side really changed my perspective about the entire field. I went through the waiting list period with him, the operation and the post-operative recovery. After that point, everything about the field for me changed. What I don't think people understand is what's going on inside of the mind of the person that's trying to deliver that kind of care. In doing lung transplants, we had both great successes and also devastating failures. As head of the transplant program at Stanford, I handled that huge responsibility and sometimes wore it well and sometimes didn't wear it as well. I think that I have been able to tell these patient stories, and in doing so, I reveal a lot about them, but I also reveal a lot about me as somebody that's delivering that kind of care. One thing that I write toward the end of the book that I think will be interesting to readers of all kinds is, how do you develop a life that has balance to it? And balance looks different for different people. So I'm hopeful that someone picks up my book who's first starting out in their career, no matter what it is, and looks at my example as not something to avoid entirely, but a cautionary tale about what can happen if you get too tightly wrapped up in what you're doing.
Welcome, and thank you for joining us this evening. I'm Dr. Lee Ham, the Senior Vice President and Dean of the Tulane University School of Medicine and the James R. Doty Distinguished Professor and Chair. We're thrilled to host tonight's virtual event and to share the stellar work and lessons to learn from alumnus and School of Medicine Board of Governor member, Dr. David Weill. Dr. Weil will share his personal experiences as life as a transplant physician. As physicians, we all have highs and lows. Creating balance, as you will hear from David, and how he has accomplished this is extremely important in our lives. Tonight, he will convey how you can do the same. He's a double alumnus of Tulane, arts and sciences in 1986 and medicine in 1990, and then went on to an extremely illustrious career. Former director of the Center of Advanced Lung Disease and Lung Transplant at Stanford. He's currently the principal of the Weil Consulting Group, which focuses on improving the delivery of transplant care. His writings have appeared in the Wall Street Journal, the LA Times, USA Today, Salon, Newsweek, the Chicago Tribune, Stat, and the Washington Post. He's also been interviewed on Fox, CNN, the New York Times, the San Francisco Chronicle, and the Wall Street Journal. This is in addition to his medical and scientific publications. Our moderator this evening is Beth Bailey. Beth is a freelance writer whose work has appeared in the Washington Examiner, the Federalist, Coffee or Die, and Detroit News. As a former Army civilian intelligence analyst, Beth enjoys writing about the needs of service members and veterans and sharing their stories. Working with the Justice Department to build extradition cases against war criminals and has led to a passionate advocate for Holocaust education and for fighting resurgent anti-Semitism. As she works on a novel on her own, Beth loves reading exceptional books. She's a graduate of the College of William and Mary with degrees in German and government. She lives in Southeast Michigan with her husband, children, and dogs. So it's a pleasure at this point to turn the program over to Beth and David.
Thank you, Dean Ham, for that warm introduction. And thank you to Tulane University and Dr. Weil for having me here tonight. It's an honor to be here with all of you to talk with Dr. David Weill about his new memoir, Exhale, Hope, Healing, and a Life in Transplant, which comes out next Tuesday, May 11th from Post Hill Press. Dr. Weill's memoir is filled with compelling stories about his 20-year career as the director of lung transplant programs around the country, most recently at Stanford University. Exhale offers an intimate, intriguing, and heart-wrenching ride through the world of transplant, which sometimes involves granting patients extended life, but often results in complications and tragedy. For Dr. Weil, the emotional roller coaster of his career ultimately pierced the facade of stoicism created by his medical training and left him struggling with physician burnout. In 2016, Dr. Weil left Stanford and moved his family to his hometown of New Orleans, where he started Weil Consulting Group. At the same time, Dr. Weil was challenging his feelings of personal responsibility for good and bad transplant outcomes, slowing down his frenetic pace and reconnecting with his emotions and his community. Those years of healing ultimately allowed him to return to the work he loves, of healing transplant patients, in 2019. As a memoir, Exhale is fast-paced and enthralling, but it also transcends its genre in several notable ways. By sharing the stories of patients who yearn to breathe so that they can do things as simple as learning or running for the first time, singing in the church choir, or being a better wife to their spouse, Dr. Weil opens up a very powerful pathway for empathy and appreciation. And by weaving in his own unabashed internal conflict, his descent into burnout, and his path toward healing, Dr. Weil offers readers an example of how we can overcome our own addictions to things like work and busyness and find a life of deeper meaning. For the first section of our program, Dr. Weil and I are going to delve into the memoir and look at several passages from the book. And then towards the end of the hour, we'll be opening the floor for your questions. So please send those in through the chat function, and you can do that throughout the presentation. And now, without further ado, I'd like to introduce the author, Dr. David Weill. Good evening, Dr. Weill.
Thank you, Beth. It's great to be here. And thank you to Dean Ham and the organizers at Tulane for having me. This has been a fabulous process getting prepared to do this, so I really appreciate it.
Well, it's very exciting to get to talk to you about what I think is just an excellent book. I'd like to open things up tonight by talking about the role of a transplant program director. So in your job, you developed very close relationships with your patients because you're working with them from their initial placement on the wait list through to pre and post surgery, and then ideally for years following their initial transplant and sometimes even a subsequent transplant. Now, in a perfect world, you would be able to get a fantastic set of lungs and an uncomplicated surgery for every patient in your care, but the reality is not quite that way. Could you tell us a little bit about the difficulties that come with lung transplant and how you were affected by losing patients that you cared about deeply?
Yeah, I can. What drew me to the field initially was the relationships that we were able to develop with the patients. We, as transplant doctors, see patients at their most vulnerable. So they're literally on the cusp of death when we see them. And so we get to know them in a very intimate way. And we not only get to know the patients themselves, but we also get to know their family members. And so what attracted me to the field was these relationships that would develop at this precarious moment in their life and then go on for years afterwards, such that they really did become part of our transplant family. And that included going to birthday parties, weddings, anniversaries, all sorts of different things. And I still gratefully hear from my patients today through social media and email. So the relationships are really what drew me to the field.
That's excellent. There's one story in particular that I think illustrates those relationships and an especially close bond you had with one of your patients. You call the young woman Tina, or Dr. D, and she was very special to you. And one of the most moving segments in the book is when you explain how you felt when you had to remove Tina from the wait list. I'd love it if you could read from that segment of the book this evening.
Yeah, I will. And just a little bit of background about the young lady that I called Tina. She was one of my favorites, and we're not supposed to have favorites as doctors, but she was mine. She was my kindred spirit. She, after her transplant, did very well. Skydive, hiking, skiing, doing all the things that you hope patients do when they get a new chance to breathe. But what really attracted me most to her was her attitude. She was the kind of patient that I would walk through the clinic door and her feet would be up on the desk. She'd be looking at the computer at both her laboratory results and the results of other patients that would violate about 7 or 8 hospital policies at any given time. And she was the kind of patient that would use profane language, which also was attractive to me. And she would also call me by my first name and sometimes even call me Davey as opposed to David, which no one else really called me. So I pick up the story in the book about 8 years after we had transplanted her, and she had developed a complication that got her back on the waiting list again in the fall of 2015. Late one night, I sat in the ICU at Tina's bedside. She'd begun to deteriorate from chronic rejection of her lungs, and I had put her back on the waiting list for a second transplant. My feet were propped up on a chair, and I stared at the bedside monitor, the blips from the screen lulling me into a trance. Tina was heavily sedated, her nurse working quietly on the computer in the corner of the room. I was glad I didn't feel like talking. Tina had become increasingly sick in recent weeks. As we sedated her so we could put her on the mechanical ventilator, I whispered in her ear, "Not a problem, kiddo. I got this. Piece of cake. One set of new lungs coming right up." In her typically blunt way, she had told me she was dying like a dog. And she was. She knew it, and I knew it. All I could do was stare blankly ahead and pray for lungs to come. I loved Tina like a daughter, and I hadn't been able to accept that my favorite patient, my kindred spirit, wasn't going to make it. I had subconsciously decided that if I said Tina was still eligible for a transplant, then she was. And if she was, we could still save her. It was time to have a discussion with her family about the details of the end of her life, but instead, I spent my time scrambling to get her relisted for another transplant and assuring her parents that things were going to work out. I'd known it was a long shot, and as I sat there in the ICU, it was clear that we would not find a donor lung in time. She was too sick for that now, and it was time to say goodbye. "Come on, David," I could hear Tina say in my head, "do something." "Doesn't it look like I'm trying?" I replied to the voice in my head. "I'm not God." I found my internal monologue was simultaneously explaining my position and begging for her forgiveness. "Not God? That's pretty clear." I could almost hear Tina's high-pitched, nearly maniacal laugh and imagined her red hair flying as her body convulsed hysterically. I smiled. "Tina, you're killing me. You and all the others like you." "More like you're killing us," I imagined her saying with a hysterical laugh. Tina always got the last word, even on the way to the other side. I stood up and went to her bedside. I touched her face and it felt cool, not as cold as a dead person, but not as warm as someone fully alive either. I leaned over and kissed her forehead. "Dr. D, I'm sorry." Tears came to my eyes, and it was time to go talk to her parents. It was also time for me to face some facts about my career. Continuing to do this work the way I was doing it was not sustainable. I needed to get off the merry-go-round. I just didn't know how. I didn't think I could stop myself. Transplant was my duty, my responsibility, and what I was trained and programmed to do. It was hard to imagine leaving my post, but I needed to find a graceful exit, an elegant off-ramp that would satisfy my need for a tidy conclusion. One way or another, I wanted off the roller coaster. That had been my life for nearly 20 years, and that was enough. For me, the job was no longer a pure and simple exercise in rationality. I had mastered the mechanics of being a transplant doctor. That was the easy part. But now, from an emotional standpoint, every wife was my wife, every child was my child, and every father was my father, and I needed to save them all.
Such an incredible part of the book. And I think perhaps one of the reasons losing Tina was so difficult was because it flew in the face of your very deep belief at the time that you could personally secure a positive outcome for every one of your patients if you just worked hard enough, and you were working incredibly hard. Have you found that that belief is normal in the medical community? And more importantly, is it healthy?
I think it's common, but not healthy. I think that particularly physicians, I think of my generation, were trained to think that if we did work hard enough and smart enough, that we can control the outcomes. But part of growing from an emotional standpoint through the years of doing this kind of work was realizing that you can't control the inherently uncontrollable, that we play a part in all of this naturally in how patients do, but we're not the only part in how they do. And that was amazingly hard for me to accept. And I really didn't learn that until I became about 50 years old. So I'm a slow learner, and it didn't really occur to me till then that that was the case.
And you were so driven at the time to succeed for your patients that it seems like it masked some of the initial symptoms that you were suffering from burnout. And it was only after a series of truly devastating personal and professional losses that you came face to face with the reality that you were, as you write, burnt to a crisp. You tell the story really poignantly. So again, I'd like to return to the book here and have you read about having to notify the family members of a young woman whom you call Allie that she was no longer able to receive a transplant. Could you read from that for us and then tell us about what happened surrounding that event to make that time so difficult?
Sure. So this is another patient with cystic fibrosis who was on our waiting list. I needed to go tell Allie's family that she was not going to get a transplant, that she was going to die. But I didn't want to move. I wanted to stand there in the peace of my own quiet space, as if by not moving and not talking, I could avoid facing the fact that we had failed, Allie and her family. I wanted time to stop or go backward to a time when she was well, a time when I was in better shape too. Finally, I heard the nurse say, "Dr. Weil, what do you think?" It was as though someone was talking to me underwater. I opened my eyes and blinked against the sound of the monitors a few times, my sight a bit blurry, my thoughts unfocused. I shook my head a few times. "Thanks," I said, "I'll go talk to the family." As I came to the double doors leading out of the ICU to the waiting room, I saw Tony, her husband, and Allie's parents waiting for me in the hallway. I started in. She's very sick. I stumbled for the words, even though I'd had this talk thousands of times in the past. I felt nauseated and looked around for a bathroom. There was one just a few feet away, right next to the waiting area. I prayed that no one was in it. "Hang on, David, don't lose it. We can't, she can't get a transplant," I mumbled. I was seeing spots, at a loss for words. I grabbed Tony's forearm, less for his sake than for mine. I felt tears running down my face, and I searched in my pocket for a tissue. I didn't have one, so I used the sleeve of my sport coat. I was trying to compose myself and could see that the concern on the faces of her family was less for their daughter than for me. Tony, this kind man who was about to lose his wife, put both arms around me, and I sobbed uncontrollably. Allie's mother said, "It's okay, honey. We know how much you care about Allie. She really liked you and thought you were great." I started shaking my head. "No, I'm not great. If I were, we wouldn't be having this conversation." I told the family again, for what felt like the 100th time, how sorry I was, and I went into the bathroom. I needed to get a hold of myself and clean up enough to walk through the hospital back to my office. I shut the door, took off my sport coat, and hung it on the hook, noticing the trail of snot on the right-hand sleeve. I was still crying, but I had slowed down a bit. I looked at myself in the mirror and saw who was staring back. A lost little boy with red eyes and a runny nose. I stayed in the restroom for 20 minutes until I thought I was together enough to make it back to the office. As I slowly walked the long hospital corridor, my head was down, but my mind was sure I was done.
Such a moving segment. Again, around that event, what was occurring as well that made it so difficult?
Well, I think at that juncture, and I believe that passage was from 2015, I had lost my father recently, and that impacted me greatly. I was in quite a bit of grief from that. I had had what I think was real empathy depletion from 20 plus years of having experiences just like that. And I think that I was out of gas. I was really focusing nearly exclusively on the failures, the patients that didn't make it, and not at all remembering the hundreds, the really thousands of patients that we had helped. And those are clear signs that a physician or anyone else is struggling when you tend to focus on the things that didn't go well and forget about all the things that do go well. And so at that point, I knew that it was time for me to step aside.
Absolutely. And when you did step aside in 2016, you went through a really lengthy process to find healing. And it was through a combination of faith, therapy, and a lot of introspection that happened for you. Was one of those aspects more helpful than the rest? And did the act of writing this book end up being therapeutic for you as well?
Yeah, writing is very important to me and always has been. I'm the kind of person that has a notebook handy all the time with scribble scratch in it. It seems as though, and I don't know if some of the listeners out there feel the same way, that I can't really understand anything that's going on with me or with something else if I don't write about it and write down words or pictures or diagrams or something. So I'm very visual in that way. So after I left Stanford and I really started writing this book in earnest, the stories came pouring out. I drafted the entire book in about 3 to 4 months, and then did quite a bit of editing after that. But the writing was incredibly therapeutic for me.
And the other aspects, the faith, the therapy, those were helpful too, because you do talk about them in the book. So what kind of role did they play for you?
Yeah, I encourage, and I work with in my consulting practice some physicians and nurses that are struggling with the same kind of symptoms. And I call them, I don't know if I made this up or not, but I call it the 3 F's: family, friends, and faith. And all 3 were really important to me. As you mentioned, I also received therapy for the first time in my life, once a week, talking to a therapist who didn't know anything about me. And I found that incredibly helpful. And one of the goals I have in some of the writing that I've done is to destigmatize mental health care. I think we've got to get over that. To me, that kind of care is very much like going to the gym. You know, we go to the gym, we exercise, we try to lose a little weight or get more muscular. I think therapy is very much the same sort of process, but it's for the mind and for the emotional state. And so I'm a big believer in nourishing your emotional state and paying as much attention to that as you do your physical state.
That makes a lot of good sense. And it's definitely, I think you've done that with this book. I want to talk about another reason you moved back to New Orleans. Obviously, you had family in the area and connections to the area, but you also have a special connection to Tulane University, and particularly to Tulane Medical School. Could you talk about what Tulane Medical School has meant to you and your family?
Yeah, it really was a big part of my family's life. My father was the director of pulmonary medicine. Imagine that. And I became a pulmonologist for many, many years. He was an undergraduate student there and a med student there and stayed on the faculty for decades. And so it was always a big part of my life. I would actually go around with him as a little boy in Charity Hospital. And when I was in medical school, he was the director of pulmonary at that point. So he was a faculty member when I was in medical school. And you can imagine that all the professors had a pretty good time calling on me, picking on me a little bit, because they knew my father well, and they could pick me out of the crowd. So Tulane's been really important to me and to my family's life. One of my sisters is a law school graduate. As Dean Ham said, I went to undergraduate and med school there and served on the board of governors. So it's part of the fabric of our life.
That's excellent. One of the interesting things, like you said, you and your father both worked with the lung in different ways. He preferred the research side and you preferred working with patients. And it was ultimately the patients that brought you back to the hospital in 2019, because you say in your book that your patients have actually given you more than you have given to them. So could you talk some about what you've learned from your patients that you've applied to your own life?
I think they've taught me everything I need to know. I call it the education of a lifetime. So we see people in my practice, and I'm sure among the listeners, they can relate to this. We see people at a very vulnerable, precarious moment in their life. We see the courage that they demonstrate to cling to their life, to fight like hell, to survive. We see perseverance through amazing turmoil that they experience. So it tends to make me, at least, feel like I'm not going to sweat the small stuff. I see folks every day fighting the big stuff. So I'm not going to worry about the small stuff. And there's something very crystallizing about facing death. And it gives you a clarity of your mind that I think I've found very valuable. One of the standard questions I ask patients when I evaluate them for a transplant, just to get to know them really and get them talking, is what would you do if today was your last day? And I think that question gets patients in the mindset of thinking about what's really important. And they answer that question probably in the ways that you might imagine: family, friends, their faith, hardly ever their job, hardly ever that somebody cut them off in traffic that day, hardly ever that they were slighted by somebody at work. That just doesn't come up. These other things do. And so that was the curriculum that I got out of doing this kind of work, and I'll value it for the rest of my life.
It's a really incredible way to look at things. And I think you've given us all a little bit of that through this book too, which is always valuable. I am obviously a reader outside the medical community, but I found that you talked about transplant in a way that was very easy for me to understand it. And I think you've made this a book that's so valuable for medical community members and so valuable for people like myself. But for many of your readers outside the medical community, I think this is lifting the proverbial veil on medicine, because the doctors you're writing about, including yourself, are flawed and imperfect. And yet you say that they deserve grace because of the extreme pressure of their jobs. You actually argue that physician burnout is a product of physicians' humanity. I hope that you could explain that a little bit tonight for listeners.
Yeah, I think, and I've thought a lot about this, I think there are a number of fields that experience similar emotions, whether you're a first responder, you're in the military, you're a Wall Street trader, you're an attorney. People respond to pressures at their job. And I think actually crying in the hospital because you just lost a young woman is perfectly normal. It doesn't feel like anything other than normal to me. And I think burnout is an unfortunate term because I think it implies that there's a mental health problem with the person that experiences burnout, that they just couldn't take it anymore. They lack resiliency. I actually don't think that's the case most of the time. And there's certainly times when mental health issues come into it, but most of the time, the person that's burning out, no matter what field they're in, is responding to external factors about their job. They have a boss they don't like. There's too much paperwork in their job. There are too many Zoom meetings. There's something about their environment that doesn't gel quite right for them. I think one of the most important terms to keep in mind is this term moral injury. And I think that that's more and more common in the healthcare field. And moral injury to me means that there's a misalignment between my values and my ethics as a person and those of the institution or the system in which I work. And I think it's incredibly common in healthcare right now. I don't know the other industries that I've mentioned quite as well, but I think when the headline blares that there's a lot of nurse and physician burnout out there, I just kind of wonder if it's in response to a system that doesn't work for either patients or the providers anymore.
Absolutely. That's such an important point. And when you talked about burnout in the book, you said that about 50% of physicians are experiencing the symptoms of what we know of currently as burnout. But since the coronavirus pandemic, I think that number is probably increasing, because there's a recent Medscape survey that says that 64% of doctors have experienced intensified feelings of burnout because of the pandemic. And so with the strains of the pandemic, the strains that doctors are already under, and the fact that many physicians are probably not going to be able to take a break from practicing right now, what advice would you give based on your own ability to find some peace in practicing to a physician who's having some difficulties right now?
I can answer that this way. First, I think when we talk about physician burnout, we could just as easily say healthcare provider work burnout or nurse burnout. It's pretty much uniform across all healthcare disciplines. But having said that, I think the coronavirus pandemic has just exposed the burnout epidemic that's been going on for some time. You know, there's research that's going back, a decade or more, talking about the problems that healthcare workers are facing, and many are looking for an early retirement, transition to another field, anything to avoid being stuck in a system and an environment that doesn't work for them. What advice I would give them is stay connected. I think the one mistake that I made during the course of experiencing some of these emotional ups and downs is isolating myself. I would come home, I wouldn't talk about what was going on at the hospital. I would stick my face in a book or put a football game on and just kind of veg out that way. You've got to stay connected to the people in your life. You've got to tell them what's going on. You've got to seek professional help when you need it. We've got to not be afraid of telling people that we're suffering. And I think that in the medical field in particular, although I think it's probably common in other fields as well, we're taught to really just tough it out. All my medical mentors, their answer to almost everything was get back out there, work harder. And that's probably common among first responders. It's probably extremely common in the military, Wall Street traders, you name it. So I think we've culturally gotten to the point that we can hear from one another if we're struggling and not look at that person as weak or lacking resiliency.
Excellent. I want to end with a somewhat uplifting question. You do make the point that when you re-entered the hospital environment in 2019, you did find an environment that was friendlier and healthier culture than the one that you encountered when you first entered the medical field. Do you still think that the outlook for medical professionals' mental health is improving?
I do and I don't. I'll tell you why I do. I do think it's improving because I think that there's recognition that this is a problem. And I think one of the very few silver linings of the COVID crisis was to bring to light how much our healthcare workers are struggling. they were struggling long before COVID, but COVID was a very defined acute injury. There were people that were struggling before that, but I think the COVID crisis has really brought all this to light, which I think is good. I would say almost all of the hospitals with which I consult have developed programs of their own where they're actually educating their workforce about what to do if you're burned out, what to do if you're experiencing these emotional problems. And all of them involve strategies pretty much like those that I've talked about. Stay connected to one another, talk, find a colleague, find professional help, find somebody to talk to. One issue that I think we're experiencing in healthcare, and I've noticed this the last decade or so, when I started out in the field, we were socially connected to the people with whom we worked. We were friends. And I found, and I don't know if this is just me or if this is true generally, but I do hear it from other physicians and nurses. We've siloed ourselves, and this was also before the pandemic. We tend not to socialize as much with the people with whom we work in the hospital. We do our job, we come home, and we're not talking with our colleagues about, hey, this has been my experience, what's been your experience, people that have similar backgrounds and are going through similar kinds of things. And I think that we have to get back to forming a healthcare community that feels comfortable talking with one another about these delicate issues. I can tell you from my own experience, my first instinct when I was having trouble toward the end of my time at Stanford was not to seek out one of my colleagues and say and tell them that I was struggling. That was not my first instinct, but I think it should be.
Absolutely. That's fantastic. It looks like we've got quite a few questions from the audience. So I'm going to start with one of your classmates, Melanie Christine. And she asks, how do you think we can balance career and family and personal life in light of all the administrative burdens that have become part of our work? And do you think our hospital administrators will see the value in limiting work hours and numbers of patients seen each day in order to sustain our work in medicine?
Yeah, Melanie, hi. That's a great question. And I think that the hospital culture is such, and I think that this is an uncontroversial statement, has prioritized profit over purpose. And I think that a lot of the reason we have to go so fast in the hospital and see so many patients is because of money and because of financial considerations. I think we've got to get to the point where we unburden physicians from tasks that other folks could do, but that need to be paid to do. I think a great example of that is the electronic medical record, which was developed to prevent or limit medical errors, but in fact has become sort of a more efficient billing machine. And I think the physicians and nurses on the webinar would agree with that. I think that being tied to these kind of tasks are not why we went into medicine. And I think we have to continue to make the case that that's not what we're in it for. We're in it for the patient interactions. We're in it for helping people in one-on-one time with our patients. We're not in it to type on a computer and have patients see the back of our heads. That's not why we're here. And we've got to make that clear to the hospital administrators.
Excellent. I have another question from John Graham, who asks, can you tell us more about the role faith has played in your life? And it says, thank you for caring for your patients.
Yeah, so for me, and I don't want to be somebody that pushes religion or faith on anybody. It's a very personal decision and one that frankly came very late in life to me. I grew up without much of a religious background and ultimately became Catholic very late in my life. I was nearly 50 years old. I sought out faith in my own life because I was struggling, like many thousands of years before me had, with what's the purpose of all of this. And I saw too many things in the hospital and witnessed too much to think that patient's outcome was solely due to whether or not I did my job well or not. I think, in my opinion, there's a higher force. I certainly understand people that question that, and that's an individual choice. But for me, whether it's sitting in a church or reading the Bible or just thinking about my own spirituality has been very helpful for me. And it was part of the healing process for me, for sure.
All right, this question is from Jonathan Devane. The pandemic has hit HCWS extremely hard. How can we help ease the future issues, PTSD, depression, et cetera, that these folks will face?
I think, hi, Mr. Devane, how are you? I think all of the things that I talk about will help, but I think we need to partner with the hospitals. I think we have to partner with the people that we work for. One of the real issues, I think, is there's been a fairly level number of physicians over the last couple decades in the United States, but there's been a real increase in the number of administrators within a hospital because the delivery of healthcare has gotten to be so administratively burdensome. I think both of those two groups, the physicians and the administrators, have to understand what the other one's trying to do. We're not at cross purposes. We don't need to be at cross purposes, but in the hospitals that I consult with, for instance, I often hear physicians say, well, if the hospital administrators would do X, Y, and Z, my life would be better. And the hospital administrators will say, if the physicians would stop complaining, then things would go better. I think we need to stop doing that. As a matter of fact, in one of the hospitals I'm working with right now, I asked the physicians to hang out with the hospital administrators for a few hours one day, and the hospital administrators to hang out with the physicians for one day and walk the hospital with them and see what they're up against. And I got on a conference call with them recently and they said, wow, I just didn't know. So these folks have been working together in the same hospital for decades and they had no idea what the other one did. I think that's got to change. I also, just on that other point, I would also say that as physicians, we need to form not so much a labor union, but we have to form a network of people within each community that we can talk to one another without feeling like there's going to be some kind of blowback. If it's not somebody in the same hospital, do it in the hospital down the street or across town. Form some kind of networks within each city that'll be a sounding board for folks that are struggling. I think that's really important. If you isolate yourself, there's nothing good that's going to happen from that.
Excellent. Here is another question about the coronavirus pandemic and the future of transplant, which I know you've talked about recently quite a bit. It's from Suzanne Egan. How do you foresee the coronavirus pandemic affecting the future of transplants, from the number of people who will require new lungs as a result of the virus to the number of donors whose lungs may be unsuitable for transplant due to effects of the coronavirus?
It's a great question and one I'm thinking a lot about and working on almost every day. So far in the United States, there's been about 100 lung transplants that have been performed for COVID-19 pneumonia. Those have all been, as far as I can tell, in people that are acutely sick with the coronavirus. In other words, people that cannot be weaned from the mechanical ventilator or ECMO support, and the only way to get them out of the hospital and have them survive is through a lung transplant. That number is going to go up for that acutely ill group of patients. The group that concerns me the most, and this is again looking down the future a little bit, are the people that have COVID pneumonia, recover, go home, but are left with a scarring process in their lungs that ultimately leads to their requirement for a lung transplant. In other words, they don't fully recover. They're long haulers in certain instances. And those folks a year or two from now might very well need a lung transplant. I hope I'm wrong about that, but that concerns me. I think to answer the question, also looking not just at the recipient side, I think we have to get better, smarter, and faster at testing donors for COVID-19. There's already been one report of transmission from a donor to a recipient of the coronavirus, which is obviously a devastating outcome. So I think we have to get better at screening those folks with more accurate testing.
Absolutely. This question is from Amalia Landa Galindez, and who asks, what would you recommend to a medical student interested in a career in surgery? How did you get interested in transplant surgery as a specialty? Did you have a special mentor or special experiences in general surgery? Or I suppose, yeah, you can.
Yeah, so I'm a transplant pulmonologist. So my training is in pulmonary medicine and then transplant pulmonology. I had great mentors, both on the cardiothoracic surgery side of things and on the transplant pulmonary side of things. My early mentors were at the University of Colorado, where I did my fellowship training. I think that back in that period, this was back to the early 90s, transplant was brand new for lungs. And I really felt like I was on the ground floor of a newly developing therapy. And Marty Zamora was my early mentor, and I write about him in the book. And, you know, big personality, big character, but taught me a whole lot about how to care for these patients. And I think most importantly, taught me how to commit to what we were doing. You know, in other words, really go all in. And sometimes I took that advice too close to heart, but I really appreciated his training of me.
All right, this is from Molly Lingua. I work in the home care setting. What are your thoughts about weaning those with COVID-19 pneumonia late effects off of oxygen?
I think that we should aggressively do that. I think, like all patients who are trying to wean off of oxygen, we should only do it when it's safe to do. What worries me, and I think I touched on this a little bit, is what worries me is that we're not going to wean some of those patients off of oxygen, and the younger patients in particular, and those without any other comorbid conditions, are ultimately going to need to be evaluated for a transplant. So that might be kind of a second wave of transplantation that comes as a result of the coronavirus.
All right. I think we have time for one more longer question. This is from Teresa Barnes, who says, your stories of life and death are so compelling. It seems your level of compassion, passion, and empathy are what may have led to your burnout. As a patient advocate, it is also exactly what makes you the best kind of transplant doctor. So many are like mechanics, only they work on human bodies instead of car bodies. Is there a way to teach others a balance so that doctors can possess and express a healthy balance?
Yeah, I think that in my observation, and thanks for the question, in my observations, I think that there's transplant doctors and doctors of all kinds, really, that are highly empathetic and highly analytical. There's hardly ever both of those operating in the same person at the same time, just my experience. I think when you have both of those traits working at the same time within the same person, you have to be cautious. And I think that my kind of full steam approach, while I was getting torn up by the patients that didn't do so well and I felt responsible for, was not the best combination. And so what I have had to learn to do is temper my own expectations of the outcomes, you know, be more realistic about whether or not you can control the uncontrollable. And I think that that's something I'm trying to teach. I'm giving a number of talks around the topics within the books. And what I'm telling medical centers and people I talk to and audiences and transplant facilities is just be aware. Just be aware. Be aware of that overwhelming force that many of us have to try to bear the responsibility fully for the patient's outcomes. I think if we're just aware of that, just that one trait, I think that we'll be able to temper that in most cases.
Excellent. And actually, there is one more question from Mohammed Abbasi, and you do talk about this in your book. What was the main reason Stanford's program was having poor outcomes before you joined? Was it patient selection or was it surgical complications?
When I joined the Stanford team, it was like an old house that needed renovation. They actually had the good bones and the good structure, and they actually had 3 very good transplant surgeons when I came to Stanford, now almost 20 years ago. The attraction of working with folks like that is what got me to move my family out to California when I had no plans to do so. I think that what Stanford was missing was the medical component, the postoperative care, the careful selection of candidates, the donor management and selection. To do transplant well, I tell the folks that I work with, you only need to do 3 things. You have to have a great surgical team, a great medical team, and a great administrative team. And it's fairly uncommon, actually, to put all 3 of those components together at one time. And then the real trick is to keep them together, keep the team together. So what I see right now is hospitals that I work with don't have one of those 3 components, or they had it and lost it. So that was the situation with Stanford, and that's why the program was struggling when I got there.
Absolutely. Well, thank you all for your thoughtful questions. They were really fantastic. Before we close tonight, I want to pass the floor back to Dr. Weil to see if you have any parting thoughts.
I want to thank, firstly, again, the organizers from Tulane. They really have been outstanding, from Dean Ham all the way to the staff that put this together. It's been first class the whole way. And Beth, I'd also like to thank you for taking an interest in this project. It's been heartwarming. And finally, all of this is about the patients that we care for. And I always remember that they gave me the education for a lifetime and enough material to write, not just this book, but many books to come, hopefully. So I appreciate them as well.
Well, I certainly hope that you do write many more books. This one is really excellent. And I want to thank you for laying bare what you call your toxic addiction to work, because it's a very powerful invitation for us readers to think about the consequences of what we're doing in our own work environments. I think it's pretty clear from tonight that Exhale is a vital read for everyone in the medical community. I also think it's very impactful for other audiences. You mentioned moral injury. That's something that is talked about right now a lot in the service member law enforcement community. And I think that you share so many of the same ups and downs with them. So I think that's a really important audience for this book. And then anyone who has ever fought against bureaucracy is going to read this book and be cheering you on from the sidelines the whole way. Also, anyone who's experienced that little voice in the back of their head wondering, if their drive to succeed is coming at the expense of friends, family, and mental health. Those are the themes are going to resonate right with them. I think we're in this age of perpetual motion where multitasking is our norm and overtime is expected, and we give out badges to people who are the busiest. And in that environment, Exhale is a fantastic signpost warning us to slow down and pursue the kinds of deep connections that bring our lives meaning and help us bring meaning to those around us. So again, I'd like to thank Tulane University and Dr. David Weill for having me here and hosting this incredible meeting this evening. Thanks to all of the audience members for joining in and submitting such great questions. I do want to mention that all the participants will be receiving a recording of this event in their inboxes in the coming days, and that on Tuesday, May 11th, you can get Exhale at all major booksellers, and you can get it on Audible too, where Dr. Weil reads it himself. Thank you all for sharing your time with us, and have a great and safe night.